Dr. Piemonte published two books. One of her books is called Afflicted, How Vulnerability Can Heal Medical Education and Practice. And recently in 2021, she has published Death and Dying. Incredible, two books already. So writing books are not easy. Publishing two incredible books is fantastic. And she's passionate about bringing healing to those who are committed to healing others. She has spent 12 years teaching medical students, residents, clinicians about compassion, suffering, and the lived experience of illness and loss. She currently serves as the Associate Dean, and I'm excited to listen to her talk today about caring well without losing yourself, rethinking compassion fatigue in medicine. So excited to listen to your talk, Dr. Piemonte. Thank you.
Thank you so much. I'm really happy to be with you all today. So I'm at the Phoenix campus at the School of Medicine, Creighton in Phoenix. And I get the opportunity to come up to Omaha every so often, and really delighted to be here. So I teach medical students, I teach residents, I teach faculty, but another part of my role is that I'm a physician coach. So I coach kind of leadership and well-being coaching to our faculty, to some private clinicians, and then also coach our residents. So some of that is academic support, and some of that is just personal and professional development. So what I want to share with you today is some of what I've learned in my journey of teaching medical students and residents. I was the Dean of Student Affairs for a while, so in caring well for the medical students and that with trying to care well for them. And then what I've picked up and learned from coaching, where I get this really kind of special opportunity to get to see clinicians one-on-one and share and hear from them. So what we're going to be talking about today is just kind of what I've learned along the way, and to be thinking a little bit more critically and deeply about what we mean by compassion fatigue. So I sometimes make the joke that if anyone ever hears a talk from me, they're going to see a Brene Brown quote because I love her and I aspire to be more like her. And this one is chock full of Brene Brown quotes just for you all. So I think this one kind of captures what I want to be talking about today. So she says, one of the greatest barriers to connection is the cultural importance we place on going it alone. And we see that a lot in medicine and medical education. Somehow we've come to equate success with not needing anyone. Many of us are willing to extend a helping hand, but we're very reluctant to reach out for help when we need it ourselves. I see this a lot with people in healthcare. She goes on to say, it's as if we've divided the world into those who offer help and those who need help. And the truth is that we are both. I see this sometimes with the medical students that I teach, that the perspective might be like, I'm learning to be the professional. This is the patient who is suffering, right? They are suffering. I am not. Even though we've got students who come in with a lot of suffering, but there can be this division that I'm here to help and that I might not need that same kind of help. So some scholars in the 90s were talking about, and this is still, I think, what we're struggling with, is that for the most part in medicine, and I would say by extension medical training, disengaged care has really become normalized. That there is a focus on biological intervention, and that there's not kind of an understanding of bringing my whole self to medicine. So in the 90s, some researchers wrote, many of the practices and assumptions of medicine seek to escape the reality of suffering, usually through denying it, objectifying it, or sentimentalizing it. As humans, we're not great with dealing with suffering and finitude and mortality. And in medicine, sometimes the temptation can be to focus on the things we can measure and assess. And then we can lose sight of suffering. But this isn't because there's anything wrong with you or wrong with medicine. This is kind of the human condition to not really want to sit and grapple with suffering. This is Martha Nussbaum. She's a famous Aristotelian philosopher. And I say it's like nerd famous, right? Like how famous do philosophers get? But I don't know, here she is in the New Yorker. So she's like kind of famous. And she talks about compassion. And I think her work on compassion is really, really helpful. She says, compassion requires a sense of one's own vulnerability to misfortune. To respond with compassion, I must be willing to entertain the thought that this suffering person might be me, like this patient could be me at any moment. She says, this I'll be unlikely to do if I'm convinced that I'm above the ordinary lot and no ill can befall me. So what she's saying here is that compassion requires a sense of humility and a willingness to kind of assume those risky feelings of imagining that you too can suffer and that you're mortal. It's interesting when we look at compassion. So we say compassion all the time. We want more compassion in healthcare. But what do we mean by compassion? So if we look at like the etymological root of compassion, we can see that's made up of two root words. So we've got passion, which quite literally means the suffering of pain. So this is why we hear things like the passion of the Christ, right? It's the suffering or enduring pain. And then we have com, which is in combination or in union together. So what suffering actually means is the suffering, what compassion actually means is the suffering of pain together. Okay? So this is different from feeling bad for someone or having pity for someone, feeling sorry for someone. This is experiencing pain with them, which is a tall order. If we're running around saying healthcare needs to be more compassionate, we're asking people to endure pain because that's what compassion means. So rightfully so, people have said, this might be asking too much. What about compassion fatigue? If I'm up here saying you all need to experience pain with your patients, you might be like, I'm exhausted. Please do not ask me to do that. Absolutely. So compassion fatigue is a real thing. And the definition of compassion fatigue from the literature is kind of intuitive, a reduced capacity for compassion as a consequence of being exhausted from absorbing the suffering of others. On its face, that seems absolutely intuitive, that you see so much suffering that you actually cannot experience compassion because there is simply too much suffering that you're encountering. Okay, I want to distinguish this. This shows up differently in the literature depending on what you're reading. I think this one is helpful, distinguishing burnout from compassion fatigue. So some researchers will say that burnout can affect anyone. You could be a financial advisor and just be working too much, and you can experience burnout, or you have a terrible boss, or whatever it might be. But compassion fatigue is reserved for all of you, which is experienced by professionals who witness the suffering of others. First responders, people who are in medicine, medical education, people who are in education, might be seeing some of the suffering of their students that they can't do anything about. So compassion fatigue is for those of you in the helping professions. It's a special version of burnout for you all. The issue, I think, with compassion fatigue is that the perception is that compassion is the problem. And I want to think about this a little bit more deeply. The perception that, why would I be compassionate? Because that is precisely what's harming me. So this came from the nursing literature. A direct quote from this: it makes no sense to nurses to participate in programs to foster compassion because they believe being too compassionate is the cause of their fatigue. Not to mention that it's slightly offensive to say to people in healthcare that they need to go be remediated in their empathy and their compassion, and that you all need to learn how to do this better. That is offensive. And it's true. When we say compassion fatigue, we're implying that why would you want more compassion? It's exhausting. So what's going on here? Because we are actually fatigued. So what is going on here if it's not compassion? The neuroscience literature indicates that compassion actually does not cause fatigue. They put people on fMRI machines, and areas of their brain that lit up were actually like the reward centers, that when you can act on your compassion, it actually brings meaning and purpose back. So when you have compassion or co-feeling, this inspires action. And if you can make good on that action, you actually feel more satisfied in your work. That's what the literature says. Okay? And then compassion actually reduces burnout, improves health outcomes, and your well-being and resiliency among clinicians. It's just true. When you're able to, you think of a day where you were able to respond to the compassion that you experienced, it brings meaning and purpose to your work. Okay? So what is it then are we fatigued by? Because being in medicine is hard and painful. So there's something that we're being fatigued by, and if it's not compassion, then what is it? I tend to agree with some of the researchers who imply that it's the inability to effectively respond to suffering. And I will get more clear on what that means. But what they talk about is that when you see suffering, it incites compassion. And when you cannot make good on that compassion, that is what is causing the harm. Now, that happens sometimes when there's tragedy. I think of some of our trauma surgeons in the trauma bay. There are terrible things that happen and they can't do anything about it. And absolutely, that is going to cause some kind of moral injury. So there are those times we think of patients who are dying and there's nothing that, a biological intervention is going to help. Sure. When children die, these are tragic things. But what I worry about the most is that when it is a lack of resources that allows you to not act on that action that you are inspired to take, right? Or misaligned priorities of a healthcare organization. See patients as quickly as you can. Don't connect to them. When you cannot make good on the compassion you're feeling because of system issues, that is what I think is very dangerous and causes the fatigue that you all are experiencing. Jessica DeDecker, who does research in this area, says, "We've been frustrated in our efforts to fully experience the cycle of compassion." So you see the suffering, you feel the compassion, and you can't make good on it. I made a little schematic to help make this very clear for you. Okay, so we witness suffering, experience the compassion, and then are you able to adequately respond? And when the answer is yes, you engage in compassionate action, and this leads to a connection to meaning and purpose, to patients, to their families, to what you were called to do. But if the answer is no, I think of the physicians in the ICU during COVID and the nurses who didn't have access to PPE or for whatever reason could not act on. I think of fighting with insurance companies to do the right thing. This is where we have what researchers call either empathic distress, moral injury, or secondary trauma. This is what I think we are inappropriately calling compassion fatigue, because the compassion didn't fatigue you. It was the inability to respond. And this is where I think we are having a huge moral issue in medicine. In a lot of ways, then, compassion fatigue is a misnomer. It implies that compassion is dangerous and to be avoided. Okay? Don't feel compassionate. Stay detached from your patients. Okay? It implies that there's something wrong with you for experiencing the frustration and pain of a broken healthcare system. It's almost like a red herring, right? Don't look at social inequities, social injustice that lead to the suffering of your patients. Don't look at misaligned priorities of your healthcare organization. You're the problem. You can't handle the amount of compassion that you're experiencing. It's a nice distraction to not take responsibility for creating a healthcare environment where you get to respond to the compassion that you innately feel. I think it perpetuates these misguided attempts at professional distance. I hear this from my first-year medical students. Don't get too close to patients. It'll burn you out. And they believe it. Before they even start seeing patients, they believe it, that you have to have professional distance. So what's professional distance? This perceived need to compartmentalize, to detach. in order to protect yourself from feeling too much. It sounds intuitively right, but it doesn't work. It doesn't work because that is what leads to feelings of disconnection, burnout, going through the motions, like you're working on a factory line, not connecting to anyone. And the research shows it has the opposite effect, right? Turning away from suffering increases vicarious suffering and feelings of burnout because you're not making good on that action that you inherently feel. I also think it prevents the opportunity for post-traumatic growth. So many of us know what post-traumatic stress is. Many of you in this room have experienced post-traumatic stress. But what is post-traumatic growth? So psychologists write about this as a positive psychological or emotional change that happens as a result of struggling or suffering, life's challenges. You know this just from your lived experience, that when you go through really difficult things, you can come out the other side changed and transformed. And sometimes we go through difficult things and we just have the post-traumatic stress. But if we have the opportunity to process those experiences, which medicine doesn't often allow for, you move on, you see something traumatic and you move on to the next thing. And when that happens, we miss this opportunity for post-traumatic growth. When we have post-traumatic growth, we can have an increased ability to relate to other people. You might have a new appreciation for life. You might have stronger emotional resiliency and strength. There's all sorts of good that can come from this, but not when we're not given the opportunity to process. I like the metaphor of the Japanese art of kintsugi to capture this. So this is the art of taking broken pottery and bringing it back together. And when you do that, you have a new amalgamation, right? It's not the same as it was before, but beautiful in a different way. And what I love about kintsugi is that you don't try to conceal the cracks, but you highlight them and gild them in gold to emphasize that the cracks are part of what makes this really beautiful. And if I could share an experience from my own life to try to illuminate what I mean by post-traumatic growth. When I was 19 and I was in college, my mom was diagnosed with late-stage ovarian cancer. And I took care of her as her primary caregiver for 2.5 years before she died. And when she died, it was absolutely traumatic. It was terrible, right? She was my mom. And on the surface, it looked like I was experiencing post-traumatic growth. Okay, so I went on and I got a master's in healthcare communication, and then I went and got this PhD in medical humanities, and I talked about vulnerability and suffering, and I taught this to medical students. I wrote a book on vulnerability, and I was not being vulnerable. I was running from myself. It was so painful to go through what I went through that I just kept going and achieving. And maybe this resonates with some of you in this room of our response to grief. I did not process my pain. It wasn't until I came back to Arizona, and then a couple years later, my dad got diagnosed with terminal gastric cancer, and then he died. And I couldn't do it anymore, right? I needed to stop running and slow down and experience that pain. And when I did, it was so hard. It was the worst. It was so hard. But I think that I'm different. I can be with people's pain in a different way. I experience compassion, co-feeling. Before, I was just numb. I wasn't co-feeling with anyone. I was totally shut down. And so I think that when we have these opportunities for post-traumatic growth, it can change who we are. And in medicine, you are experiencing micro-suffering and macro-suffering all the time. And when we don't make space to process that, we just have the post-traumatic stress and none of the post-traumatic growth. I think it's important to say out loud, even though you know it's true, you are affected by your engagement with patients, even the wonderful engagement you have with patients. And Your responses, your feelings, your emotions matter. A lot of time in my coaching, it's just me making space to tell someone that their experience matters and that there are people here to listen to it. So I will say, and maybe this is controversial or provocative, but I'm kind of done with patient-centered care. I think we need to have patients at the center. No doubt in my mind, right? We need to not have the paternalism of like the 70s and 80s, and no, we do. But I think we're done with it. I think what we need to be talking about is relationship-centered care. This was also popular in the 90s. I apparently have a very retro take on all of this with you guys. Everything's from the 90s. I think we're up to some good stuff back then. So relationship-centered care was very popular for a while. We don't really talk about it anymore. So it's like my mission in life to bring this back to y'all. So here we go. Relationship-centered care, where you mattered and how you're affected by your patients, is front and center. So the tenets of relationship-centered care are that the practice of medicine is interpersonal. We know this. It is interpersonal. Relationships matter. And patient-clinician, obviously, but also patient-family and clinician-clinician or clinician-learner. That your relationships matter. And these are their 4 principles that it's founded on. Personhood matters, the personhood of the patient and you. Affect and emotion are important. We don't say that very often in medicine. Relationships obviously don't occur in isolation, and that they're necessary for health and recovery, and they're morally valuable. I want to point out that this is very similar to the ethics of care that was proposed by feminist bioethics also in the 90s. And a feminist theory on medical ethics and medicine was really important at this time, where these scholars were saying, hey, we have way too much focus in Western medicine on autonomy. We're not really talking about how when patient decisions are made, you're having family meetings or it's influenced by your exchange with them. Autonomy is not the #1 priority in medicine because people don't exist in a vacuum. These scholars also critiqued power dynamics that happen in medicine all of the time, the gender and social inequalities that affect healthcare. This was really important at that time. And they really value this kind of emotional responsiveness. You know, this is how a feminist perspective can infuse medicine with that relationship-centered care to give voice to what is happening instead of glossing over it. Rita Sharon started the narrative medicine movement, and she says, through authentic engagement with their patients, physicians can cultivate affirmation of human strength, acceptance of human weakness, familiarity with suffering, and a capacity to forgive and be forgiven. Okay, so I was on the admissions committee for a while for the School of Medicine, and if I was like recruiting a student, was like, you're gonna learn the capacity to forgive and be forgiven, they would be like, what are you talking about? Right, so we don't typically think about that in medicine. We're not walking around saying that's what you're learning from your patients. But this is why I think altruism can get a little tricky. Sure, you should not be looking out for your own personal gain when you're taking care of your patients, obviously. But altruism kind of covers over the fact that you receive so much from your patients. You learn how to show up differently in the world, or people who go through incredible loss or miraculous recoveries. Like, you learn so much, and that there is a mutual giving and receiving in the clinician-patient relationship. All right, so the question is, you might be saying, Nicole, that sounds so great, but I'm so tired and overwhelmed, and all of the things that you are feeling. So how can you re-engage meaningfully in the way that Rita Sharon just described, but also sustainably, so you are not losing sight of yourself, right? So in other words, how do you allow for that kind of deep connection without totally losing yourself? And that is absolutely a challenge. So I'll share with you a couple of things that I've learned along the way. I started seeing this pattern when I was the Dean of Student Affairs of the medical students who were coming into my office, that they kind of had this woundedness. We all do. We all have woundedness. And I might be painting in broad strokes, but I want to share some of the patterns that I saw. That they had this woundedness that felt like medical school and becoming a doctor was going to fix that. They would start to feel worthy, or that they were contributing in a way that would make themselves feel better. And so I think while we are all wounded, some of us who find ourselves in the healthcare world or healthcare education might be particularly at risk here. Some of these wounds run really deep. And I was working with students who felt, obviously, self-doubt that we all experience, unworthiness, and even feelings of shame. I would see this all the time. And I got curious about it, like, what is going on here, right? So this is Stanford psychiatrist Dr. Anna Lemke. She wrote Dopamine Nation. Some of you might have read that. She's an expert on addiction. And then she started talking about how she started seeing some of these patterns with her own physician colleagues. And she says, I think it's helpful for patients to know we are all broken. We all struggle. Being smart and being highly educated is not any protection against addiction. Physicians are all the same regular people with all the same regular problems, but the shame can be more pronounced because you're supposed to be this healer who's got it all together. None of us have it together, it turns out. Right? And in medicine, because so many people need your help, it can be easy to avoid your own brokenness. I do think there is a seduction of achievement. This is what I was doing after my mom died. If I would just achieve, I didn't need to feel. And many of you in this room are high achievers. And sometimes that allure to just keep achieving can pacify us for a while. It might draw some people to medicine, not all of you, but some of you. You could be drawn to medicine because of this. And achievement can help us feel better. It helped me feel better for like 4 or 5 years until it didn't. And that's kind of what I see in some of my coaching practice with the clinicians that I'm working with. I want to share this video with you. Anybody know Gabor Mate? Heard of his work? I see a couple head nods. He's amazing. He's a Hungarian-Canadian physician, palliative medicine, addiction specialist, talks a lot about trauma. And he works with clinicians, right? And he said, he's going to tell you here about his trauma. I'm going to say capital T trauma. I think we all have like lowercase t trauma. Some people have capital T trauma. He has capital T trauma. As an infant, his mom had to hand him to a stranger as she was put on a train to go to a concentration camp. So that's his capital T trauma. So he's had his own struggles with feelings of abandonment. And he connects this to kind of his career in medicine. So I just want to take a minute to listen to this. It might be a little loud, so whoever has hopefully it's okay.
I got the message that I wasn't wanted. That's how I interpreted the world's actions. Now, if you're not wanted, medical school is a great way to make yourself wanted because you're offering something very important to people. And when they're in crisis, they want you all the time. Very addictive because there's a hole inside you where you should be and you're trying to fill it all the time from what you get from the outside. So it's never enough. So the more you get, the more you want. So therefore, I'm addicted to working. Well, that kills joy. It also makes me absent as a parent to my children and makes me absent as a partner in my marriage. And the world admires it. And the more workaholic a physician I am, the more the world thinks I'm wonderful and the more money I make. I get all this reinforcement for my disconnection from myself. And then you couple that with the fact that I really wanted to help people. It gets so confusing. And the thing is to separate what's genuine in that, which is the desire to be of service and to engage in meaningful activity, and to separate that from the need to feel a hole in myself. This is hard work. And in society, it seduces us into that disconnection and even rewards it.
Okay. So when I first saw this, which was not that long ago, I was like, you're saying all the things that I've been thinking about. And I think there's some truth here. Not for all clinicians. I want to emphasize this. There are so many of you in the room. There are many of you Some of you in the room might not struggle with this stuff. And I very much admire you, and I'm very, very jealous of you. But I want to acknowledge that you exist. There are others of us in this room, particularly women or people who identify as women, who we tend to struggle with this. And many, many men in my life struggle with this as well, that this desire to please or take care of others, right, feels definitive and has been a struggle for us in our lives. I want to highlight a couple of things that he said here that I think are really, really important. If you're not wanted, medical school is a great way to make yourself wanted, because you are offering something very important to people, and they need you all the time. All the time. You're like, I know. Talk to me on a call night. I know they need me all the time. Okay, it's very addictive because there's a hole inside you where you should be, and you're trying to fill it all the time from what you can get from the outside. The more you get, the more you want. So therefore, I'm addicted to working. The more workaholic of a physician I am, the more the world thinks I am wonderful. I get all this reinforcement from being disconnected from myself. Okay. When we are disconnected from ourselves, that is where we step into people pleasing, right? And putting other people's needs in front of our own, and just give and give and give until we're totally exhausted. Some of you might know this book, Codependent No More. I was on my own journey and had to read Codependent No More. Turns out I was codependent. All right, so in this book that I was reading for my own life, Melody Beattie, she says something almost in passing. People in the helping occupations might struggle with codependency. And I was like, uh-oh, okay, that's me and everyone I know. All right, so codependency. Sometimes we have a misperception of what that is. So you'll hear like, oh, that couple, they're so codependent, they can't do anything without each other. You're so codependent, you can't do anything without this person. All right, that's typically what we think with codependency. That's not the definition of codependency. Codependency, this came out of the literature in the 80s, looking at people who struggle with alcoholism, and then looking at their partners. And what they found is their partners were just as wrapped up into the addictive cycle without even having a drop of alcohol. They were just as addicted to rescuing and saving that person than that person was to the alcohol they were addicted to. So both people are caught up in a dependency, even though the thing they're dependent on is different. Okay, so codependency is just taking care of people to the expense of yourself. People who love, care about, or work with troubled people may be codependent. If compassion has turned into caretaking, if you're taking care of other people and not taking care of yourself, you may be in trouble with codependency. Turns out I'm in trouble with codependency. All right, so codependency happens all the time in medicine because it is easier to focus on rescuing another person who needs us than it is to focus on ourselves and our own wounding and our own pain. If you just keep taking care of people, you don't have to slow down and say, who's taking care of me? And am I taking care of myself? Okay. There's Brene Brown again. We love her. She says, boundaries are a prerequisite for compassion and empathy. Okay, so I was talking earlier about co-feeling. Compassion is feeling pain with that other person. But an unboundaried feeling of pain is not helpful. We cannot connect with someone unless we're clear about where we end and they begin. If there's no autonomy between people, then there's no compassion or empathy, just enmeshment. And I have found myself in that place before in my own life, particularly because I didn't want to look at myself, so I could just get caught up in taking care of someone else. And then you're not actually being compassionate. It's about you. It was about me, right? And my own pain. So you'll hear this all the time, that you have to have boundaries. Who's ever been told that? You have to have boundaries. I see lots of hands. Yeah. I have been told that a lot. And I was like, I don't know what that means. What do you mean have boundaries? What does that look like? it just felt like a mystery to me of how to have boundaries, like tell people no. I don't do that, right? I'm not interested in that. All right, so I will tell you what I have learned working with others and then in my own healing journey about what it means to actually have boundaries, okay? So here I want you to think about not necessarily patience, because that's a different dynamic. Someone in your life that maybe you lack some boundaries with, or someone has told you to have boundaries with them. Okay, so what does that actually look like? This is what was helpful to me. I learned that when we rescue that person, we are not always helping them. And that was a hard thing for me to learn. I had to learn this with students too. I felt like if I could just fix things for them, then I was helping them, but I wasn't. When we rescue others, we might be disempowering them. When there are people in my life that I try to rescue, I am implicitly giving them the message they cannot do it by themselves. I have to do it for them, or I have to help them. And when I learned I was disempowering people who needed to kind of do things themselves, I was like, oh, I need to have a boundary here. I can love them, support them, cheer them on, but I need to not do it for them. And finally, when we rescue others, we prevent opportunities for their post-traumatic growth. If I fix everything for students, they're not learning in that development of what it means to be a future healer and future physician. I'm doing the work for them. And sometimes they have to suffer. Right? I had to remind myself. Sometimes they have to suffer a little bit, and that's okay. And I don't need to fix it for them. Okay, what does this mean for taking care of patients? You're like, Nicole, they actually need help. I can't tell them, if I don't help you, you're going to grow. No, you have to actually help them. So the boundaries with patients can look differently, though if you're trying to rescue patients so that you don't have to look at yourself, that's kind of, those boundaries get blurred because it's not about authentically helping them. It's about making yourself feel better. Sure, we can get into some tricky issues there, but this can be helpful for boundaries in patient care. Ask yourself what it really means to be successful. Here's the problem. Since you were, before you went into healthcare, even for those of you who are in medicine, even as a pre-med, people told you what success meant. And then when you were in medical school, we told you what success meant. And oftentimes, even if we were like, oh, it's to be compassionate or whatever, we were like, you got to pass this exam, do great on your board exams. And so that narrow definition of success, right? And then now, as a resident or as a clinician, there are still really narrow definitions of success. So really asking yourself, what does it mean? Is it to care well for somebody, which I know is inside of you and the only reason you went into healthcare in the first place? Or does success start to become something else, to achieve a particular outcome, outcomes that other people gave you, that the hospital system gave you? Or sometimes you get very attached to a patient having a particular outcome, and when they don't listen, it can be really painful. But we have to loosen our grip on that. Is it to meet a metric? Here's the thing. You might be saying, that sounds great, but this is my reality. I have to meet metrics. As a resident, I got to meet these milestones. As a clinician, I have to meet these RVU metrics. And I want to acknowledge that that is real. And I also want to acknowledge that that is what's causing the moral injury. When you've been reduced down to a transactional exchange of dollars and cents, that goes against your nature. That is causing moral injury. And we need to ask for something different. But that is a different talk. We could talk about that later. Okay, I swear this is my last Brene Brown quote. Okay, we could talk about courage and love and compassion until we sound like a greeting card store, but unless we're willing to have an honest conversation about what gets in the way of putting these into practice in our daily lives, we will never change, never, ever. I think we have to start getting real and being honest about what gets in the way of being the person that we want to be. There's so much that gets in the way of me showing up as my best self and trying to be honest about that. I want to remind you of the quote that we started with. It's as if we divided the world into those who offer help, those who give help. But the truth is that we are both. And we need to be cared for along the way. So just a couple of practical steps, I hope, that you could take with you today. What can we do to re-engage meaningfully and sustainably? I think we need to start saying out loud that medicine is like beautiful and amazing and also painful and really, really hard. And we need to say it out loud in spaces that we don't typically say those things out loud. So, I will take up your grand rounds hour and do that and tell you that it's painful and hard, and then we should talk about it. What happens outside of work affects who you are when you come into work, and vice versa. You bring that stuff home, right? And to pretend that you can compartmentalize it is just silly. You can't. You are a whole person, and you show up in all of the spaces as a whole person. Remember that if you've got medical students on your team, if you are staff in the hospital, the people around you, your colleagues, the learners, the staff, they're not fragile. We're not fragile. A lot of us are going through stuff, and to just talk about that is okay. You're not going to hurt them. Those feelings are there anyway. If something terrible happens on the wards with your medical student, don't pretend it didn't happen. Tell them it was awful, right? We are not protecting anyone by assuming that they are fragile. Normalize, ask about, be present for pain. That might mean after a terrible situation, you can just simply walk out and say, that was heartbreaking. Are you okay? And I'm telling you, the students want that. Other people want this. They want to be able to talk about this. So just say it. Just acknowledge it. They're thinking it. They're feeling it. Remember the first time you ran a code and then or you were a medical student and you watched it and participated and then you moved on to the next thing? Just talk about it. That's not normal. Normal people don't do that. Medicine is a saturation of really hard, terrible things, and we need to be able to talk about it. And then finally, I think we need to work on our own wounding so we can create healthy boundaries and to not run from it. For those of us who have that wounding, that it's time to kind of look at it. I want to remind you, boundaries are not necessarily about fewer hours worked. There is some literature out there that suggests the fewer hours you work, it decreases burnout. So that's true. I'm not going to pretend it's not there. I want to acknowledge that. But this is what I want to say. 65 hours, and I know some of you are like 65, Nicole, I'm working 80 plus. Okay, 65 hours of intense patient care where you are connecting to people, being able to respond to your compassion is so much more meaningful than 20 hours that whole week of just charting and documenting. I promise. So it's we need less of that nonsense and more meaningful work. So it's not about working less, but working in an environment that allows you to act on your compassion. I think we got to get curious about our own patterns. What are these conversations I tend to avoid? What is some stuff with patients I don't really want to be a part of? Why do I end up in these kinds of relationships? Whatever your patterns are, just get curious about them. Why do I do those things? And I think we could start seeing our struggles. I can't actually do that. I'm trying to do this in my life. I can't do it. Start seeing our struggles or failures as opportunities to grow or transform. I actually do believe this. I'm able to see my suffering this way. I'm not great at my failures was an opportunity to grow. No, but we have this tendency to hyperfixate on perfectionism in medicine and certainty and all of that stuff. But letting your students struggle and fail, they'll grow from them for sure if they have the opportunity to. And the last thing, I usually get this question well, what about time? You're asking us to just be loving on all these patients and whatever, this is going to take time. A couple of things. There are conversations where you acknowledge suffering and pain that do not take long at all. It's just acknowledging it. And those can be very brief. And this I borrowed from my colleague, Tom Lenz. He's here in Omaha. We talk about this a lot. That compassion doesn't necessarily require doing more stuff. It's a way of being. So you're going to take your same H&P or you're going to have that same family meeting. You're not doing more. You just have a openness, curiosity. You've worked on your own wounds so you can be present with some of their pain. It's a way of being. And yet, sometimes being compassionate does require more time. And that's why we need to demand a healthcare system that allows for the more meaningful work, which does take more time. And we need to not be quiet about this. This is what we need in healthcare. It makes your career more sustainable. It's better outcomes for patients. And when they reduce this to your productivity, everyone is suffering. I have no doubt about that. I'll end with the beginning. Many of the practices and assumptions of medicine seek to escape the reality of suffering. And I will remind you from Viktor Frankl, wrote this in Man's Search for Meaning, we give our suffering meaning by the way in which we respond to it. Right? And we need to create spaces in medicine where people can think about, respond to, and make meaning of their suffering and not pretend that it's not happening. It's happening all the time. And we need to just open up space to be present with it and to be present with each other. I have more resources if you're curious that I'll put up for you. Maybe we can share these slides and you can have all my citations if you're interested in any of this. But I want to take time now to hear from all of you. The best part of this is when I just shut my mouth and get to hear from you. So if you have questions or thoughts, we've got a microphone too, stuff that's coming up for you, things you disagree with, please, those of you who are on Zoom, you can type it in the chat. And those in the room, I would love to hear from you. So I'm going to hand it over to you all right now. Don't be shy. Yeah.
Julie Granetsky, president. We have a vice president for CFO for finance, chief medical officer. And some of the things that I'm very proud of that Dr. Pritza has done too is that nationally working to bring down productivity, bringing down the standard of like 65% to 50%, just to kind of connect with patients, right? And then also we have a lot of work we're doing on physicians and APP engagement. And one of the things that we have done is what you said about patient-centered, really focusing on it's not just patients, but we have provider-centered too. But I'm going to use your wording now. Go back to the 90s and use your wording. Yeah.
If Gen Z's doing it, we can do it. Yeah. Thank you so much. Yeah. Absolutely. So I'm super encouraged to hear that. So my CHI, Common Spirit people, love to hear that. That is so awesome that you're trying to create the structures that make this kind of care possible. So thank you for sharing that.
Any other questions?
Thoughts, questions? Yeah.
What do you suggest for the patients that you can't relate to? The person who has a swastika tattooed on their face or...
Yes. Thank you for that question, Dr. Townley. So there are patients that you will immediately be repelled, repulsed by, right? That's part of being human. My strategy, what I try to do is the question I get a lot is, what about the patient who comes into the ED and they're like drug seeking or, right? And you're feeling manipulated by them. They're trying to manipulate you to get what you want, what they want. That is so hard and frustrating. And you just want to leave and you're mad at that person. What I try to imagine is that when she was 4, 5, 6 years old, she didn't say to herself, I cannot wait to grow up and manipulate people in the ED for drugs. She's broken and in pain and has a bunch of trauma. And if you can just like hold on to a shred of that and care well for the imagined 6-year-old that she is, it might make it possible. That's the best I've got with that because I know it's so hard. But trying to imagine who they wanted to be versus who they've become can help us see them as a full person. So thank you for that question.
In the utility plan.
Yes. Let me hand this to you, Father-in-law.
Thank you, Dr. Piemonte, for a wonderful presentation. Does the concept of human dignity help and reflecting on that with a difficult patient or all this, I guess with a difficult patient in front of you, just to be reflective about, and I think you just touched on that with Dr. Townley's question, but just the concept of human dignity, that everybody is created in the image and likeness of God. And that is so helpful just to kind of reset things. I just throw that out there.
Yeah, thank you so much for that, Father Embach. So the human dignity, and I think that's what it gets at. Like sometimes when I think of human dignity, it's like so abstract, and it's like almost to remember someone childlike. And some people might say like that's the image of God, like childlike, is easier to kind of care for and respect a person like that. So I think those are totally related. So thank you for making that connection.
Dr. Piemonte, really grateful for your presentation. We have a lot of young physicians in training in the room and others. And you made a powerful point about vulnerability. And I think we need to hear that more.
Yeah.
It's still equated to being weak and not being enough. So I just want to express my gratitude to you on behalf of all of us and the residents and everyone training them and other women in medicine. So thank you so much.
Yes. Thank you. Thank you so much for saying that. I will say that in the coaching space where I get to work one-on-one with residents, one-on-one with physicians, that vulnerability is absolutely there. And I see it one-on-one. I probably work with like 75 residents, maybe more, they're just kind of come in. And I see that vulnerability one-on-one every single time. And it breaks my heart that can't be part of the ethos of medicine. It's there one-on-one, but it's not part of the ethos. And so I'm hopeful things are changing. I really am hopeful things are changing. I feel it for sure, especially with those young medical students. Feel it for sure. So I think that things are changing and I'm hopeful for that. So did anything come up on Zoom? I kept seeing things pop up. If not, oh, no one's even manning it. It's totally fine. Okay, you all.
Yeah. We have a question here.
Okay, great. Okay, so thank you all. Oh, I have one more. Sorry.
Thank you. This was an amazing talk. And when you talk about compassion fatigue, I think all of us go back to COVID. Those of us who worked inpatient during that time. And I think just you rephrasing what compassion fatigue is, what other points would you have to just address that each day? Because now we have this in our mind that we all have compassion fatigue, and how do we kind of counteract that?
Yeah, great question. Thank you for the work that you do in this world. That is so important. So I want you all to forgive yourself like every step of the way. So it is true that you are full of compassion, even if you haven't tapped into that in a long time, even if you feel totally numb. Know that there is nothing wrong with you and everything wrong with the world in which we can't care for people well. Right? Like, is it your fault that these people that you're seeing and taking care of don't have access to healthy food or don't take care of themselves, have their own trauma, and then they're showing up in front of you and you're being asked to fix and help in a way that you cannot. You can't. There's so much that's broken, and putting the onus on Western medicine to fix a very sick person in front of you without having the resources you need is unfair. And so that is the moral injury. So let's work on reminding ourselves that it's a moral injury, has nothing to do with your compassion. And to choose to show up every day to care for people in a broken system is almost absurd. And I admire you for waking up in that absurdity and choosing it anyway. Like, that is a gift to the world. And so forgive yourself, have compassion for yourself, and know that it's not you. And just keep trying to love people the best way that you can.